Affect nearly every step of the process of conception and carrying pregnancy. It can lead to ovarian failure, testosterone failure in men. It affects implantation, and it affects the ability to carry a pregnancy to term. Okay? In the ovary, autoimmune reactions have been identified against several different ovarian tissues. Granulosa cells, theca cells, you name it, we've identified autoimmune reactions. There's no diagnosis yet around ovarian autoimmunity. This is, again, what gets picked up in the kind of preclinical research. About 20% of women, it's estimated, with premature ovarian insufficiency have autoimmune contributions to it. And I'm going to kind of skip some of the details, so I want to make sure we get to the really good clinical stuff, but you have this in your notes. Okay. So what is this kind of spontaneous premature menopause? Sometimes we see this premature ovarian insufficiency. Women under 40, normal karyotype, menopausal level FSH levels, so very, very high, over 100 or higher. Sometimes you'll see oligomenorrhea or amenorrhea. There's no other cause that we're able to pick up, and oftentimes they also have Hashimoto's thyroiditis. So when you see that, you want to make sure you're testing ANAs and looking at autoimmunity as an underlying factor, because about 1 out of every 5 women will have that as their underlying driver. You also can have autoimmunity to steroidogenic enzymes. About 4% of women with premature ovarian failure test positive for this. Okay. Sometimes what you'll see, you can pick it up in women who have a false diagnosis of PCOS, essentially, because it can lead to more like follicles being seen on the ovary. And so if you have a woman who's been diagnosed with PCOS via ultrasound and things aren't really coming into clarity with you because they don't fit a PCOS picture, you might think about looking at autoimmunity as another reason for that to show up on an ultrasound. Again, I'm sorry to move forward, but if you wanted more details on this, you can certainly ask me questions after the talk, but I want to make sure we get lots of great time to talk about some of the clinical pieces. Another area where autoimmunity affects the ovary is lymphocytic oophorytis. Okay, this has a strong correlation with Addisons disease and adrenal antibodies. When this gets picked up, which again, this is more in a research environment, it's not commonly tested for, there can be autoimmune reactions in the ovaries that get picked up. Almost always, those women also have essentially early preclinical Addisons disease. Okay. One study of women with Addisons disease showed that in 90% of them, they had premature ovarian insufficiency prior to being diagnosed with Addisons or prior to having any kind of clinical symptoms of Addisons. So possibly premature ovarian insufficiency could be a marker for Addisons disease, which is really interesting to me because I love the adrenal glands and I see so much how adrenal function positively impacts fertility or negatively impacts fertility. And I wonder, are these two things, premature ovarian insufficiency and Addisons, are they connected due to autoimmunity, or are they connected due to the fact that the adrenals are so poorly functioning now that impacts fertility? We don't know, but likely both. So when you see autoimmune premature ovarian failure, you need to look at endocrine health, emotional health, reproductive health, genetic health, take a real holistic approach. So let's talk a little bit about some of the diagnostic testing that you can do here. So again, this is what you might run on a patient with premature ovarian insufficiency that is unexpected. Okay. There's a few clinically useful tests that you can do. The first is 21-hydroxylase. This is used to diagnose Addisons disease or another less common autoimmunity called APS. Also, you can measure thyroid peroxidase. We've talked about anti-TPO antibody. And then the next thing that you could do would be genetic testing for things like Turner syndrome or other mosaic illnesses. And when you see this, typically in conventional medicine, they'll recommend a donor egg. But one thing that's really interesting about ovarian autoimmunity is that it tends to ebb and flow. So you'll have some cycles that are really kind of failed cycles where ovulation won't occur or where the eggs will be really poor quality. But then you'll have another cycle that's perfectly normal. It's very weird, but the disease can ebb and flow. So women might have fertile cycles. So if you have a woman who's been diagnosed with this, it's not necessarily all hope lost, and donor egg might be their only option. If they have the time and the energy and the headspace to keep trying, they might be able to catch a cycle that's normal and get pregnant on their own. Anti-sperm antibodies, kind of a little bit more of a controversial diagnosis. This can happen with women and men though. It was originally described in 1954 where they looked at semen analyses and they found 2 men exhibiting sperm agglutination. I see this a lot on semen analyses, agglutination, right? The prevalence data is really limited, particularly in women. In men, we know a little bit more because we're looking at semen analyses. But antibodies can be located in male or female serum, in semen, in ovarian follicular fluid, vaginal secretions, or in the sperm membrane. So antibodies can exist in a lot of places to men's sperm. Okay? And one study showed in couples with unexplained infertility, when they run anti-sperm antibodies, 7% of men and 13% of women carried anti-sperm antibodies. Okay. Another study, they did ELISA assays, which are antibody assays for anti-sperm antibodies, and they found that 77% of women with unexplained infertility carried these, 75% of women with endometriosis, 60% of women with some kind of fallopian tube infertility. Only 5% of women in the control group carried anti-sperm antibodies. So again, this may be another really underestimated reason for unexplained infertility. In men, consistently men show rates of between 10 and 15% of carrying antibodies to their own sperm. And then you'll see agglutination on a sample where the sperm start to kind of clump together. There's no standardized testing, unfortunately, at this point. I've listed for you a couple of tests that are out there, but none of them have really risen as the most reliable test. And then when it comes to treatment, conventionally, the treatment regimen really has 3 parts. The first is to reduce or decrease production of anti-sperm antibodies. One of the best is condom use for this, which, with immune system, in order to make a lot of antibodies, you need a lot of stimulus, right? The more you see the antigen, the more antibodies you make. So the less you see the antigen, with condom use, especially if it's the woman who's making anti-sperm antibodies, if you used enough condoms for enough time and the immune system didn't see the antigen for a long period of time, the antibody rates would come down and the reaction would be less strong. Okay? So if a woman has anti-sperm antibodies, I recommend condom use except for the conception attempts, all month long. And I remind them it's not because I think they're going to fall pregnant outside of the right time. It's because their body is recognizing proteins in their partner's semen as problematic and it's triggering the woman's immune system. Okay? That's a weird conversation to have with partners too. And I have actually sat with a couple of women who have, created they've asked the question, like, if my immune system is creating antibodies to my partner's sperm, is this the right partner? Am I with the right guy? Or is this some kind of universal way to tell me that this is not the partner I should be with? So I've had that conversation to talk them back off the ledge. No, it's just a confused immune system. It might have been mono that you got when you were 16. That you're having more reactivity here. The next is to remove the antibodies that are already bound to sperm. This is really important if men are making antibodies to their own sperm, and that's the role of sperm washing. So this might be a reason why a very fertile couple may go through IUI, because they can collect and process the sperm, wash away the antigens, wash away the antibodies prior to insemination. And conventionally, they oftentimes will do IVF. Anti-sperm antibodies significantly decrease success rates, but when sperm washing comes into play and they use ICSI, pregnancy rates can come back up in couples who are positive with anti-sperm antibodies. So that's the conventional approach. From my perspective as a naturopath, condom use is really important. There's also been some interesting data on systemic corticosteroids being used. Don't worry, I'm not going to recommend that prednisone prescription. But the studies look at about 20 milligrams of oral prednisone, and there is some limited efficacy. It's limited, but for some patients it works. So prednisone is a massive immune suppressant, right? The steroid. So I always think about what can I do to combat that inflammation, and you'll see this theme come through the remainder of the approaches to autoimmunity too. What can I do to help suppress or manage the inflammation? So I think about what you have in your toolkit for that. The biggest one for me is curcumin, boswellia. Love some of those botanicals to really help to lower inflammation levels. If you're working with a man and he's been on prednisone, also in case, for some of you acupuncturists might be new, the use of licorice concurrently with prednisone can severely decrease the negative side effects that occur with longer-term prednisone use. So you can co-administer licorice, and that can be really helpful. Okay, this is the area that I was mentioning that also one of the things we're looking at with autoimmunity is just the impact of generalized low-grade inflammation on the reproductive system. This is an area I'm really excited to learn more about and see more data come out. Newer research, like 2016-ish, identified what's called an inflammasome, which is this kind of cluster of inflammatory cytokines. I've listed some of them here. There's interleukins, capsase, et cetera. And what they did was they looked at 30 fertile women and 30 women with recurrent pregnancy loss, and they took endometrial samples during the time frame when they would normally be implanting, where implantation would normally occur. And what they found was this increased activity of this inflammasome in the group with recurrent pregnancy loss that didn't exist in women without any known history of pregnancy loss. So it's thought that there can be some kind of autoimmune inflammation going on of the endometrial tissue. Again, we don't know. The trigger might have been an infection. It might have been damage that occurred at some point. We don't know what triggers that, but what we do see is this heightened level of just generalized inflammation occurring in the endometrium, and that can be really associated with infertility and loss, pregnancy loss. Okay, this is a new area, and I think a really exciting area for future investigation. And it's something that I already am working with clinically and seeing positive results on when women, particularly, I find this interesting, like IVF. I wish that not as many women pursued IVF. I wish they came to us first. I feel like we could help so many people. But one thing I am so grateful for with IVF is prior to that, we had really no data on what was going on with women when they were having difficulty conceiving. And now with IVF, they can measure the impact of all these different steps of the process. So for example, if a woman has great embryos and they've been, they're very high quality and she's not getting pregnant, it can help you pinpoint that it's an implantation issue versus an egg quality issue, which when you're working with a woman with natural conception, you don't have that kind of information. Right? So thank you, science, for this additional information on all the different things that can be happening and help us to pinpoint a diagnosis and really get a good strategy in place for how we might help them from an integrative perspective. Okay? This is an area when we look at failed implantation rates, which I'm seeing more and more, this is something that can be part of the issue and part of something that you might think about addressing. So how do we manage all of this? Okay, there's a lot going on. The good thing is clinically, the approach I take for autoimmunity matters less what specific autoimmunity they have. I care less about what specific antibodies they carry. What you're going to see is kind of a more generalized approach to women who are coming in with any kind of autoimmunity, and then you might add on something to protect or support a target tissue like thyroid, if that's part of the autoimmunity that's going on. That would be an addition. Okay. So when it comes to approaching autoimmunity, the integrative medicine paradigm explains that autoimmunity requires really three things. Genetic predisposition, tough cookies, we can't do too much about that, right? We can for the next generation by healthy preconception care. Exposure to some kind of trigger. We'll talk a little bit about what some of those triggers are. And then intestinal permeability. These are like the three things that have to be in place in order for autoimmunity to exist. Okay. We know patients with any kind of autoimmunity, they have higher amounts of a protein called zonulin. Have you guys heard of zonulin? Zonulin actually increases intestinal permeability, but thankfully it's reversible. You can bring zonulin down and those cell junctions between the cells and the intestines can actually get better over time. In order to stop autoimmunity, you also need to do three things. Reduce triggers, Okay, you need to reduce lookalikes, you need to reduce toxins. That means if someone has a latent viral infection, you might need to help them clear that, like Epstein-Barr, which you may never clear, but at least decrease the level of the virus in the body. Or if a toxic exposure is going on, you need to address that too. You need to eliminate intestinal permeability, otherwise known as fix the gut, heal the gut, and then provide the nutrients needed to repair and re-energize tissue and get it healthy again. So reducing triggers. We're going to kind of talk through each of these three things. So one example would be iodine. Iodine is a trigger for Hashimoto's thyroiditis. Okay? So oxidation of iodide to iodine by TPO, thyroid peroxidase enzyme, produces hydrogen peroxide. And normally that hydrogen peroxide gets neutralized by my very favorite thing called glutathione. You guys all know glutathione? Know and love glutathione? But if people are deficient in glutathione, which can be genetic, it can be epigenetic, it can be nutritional, there can be environmental, or if they're low in selenium, then the oxidative stress level can start to rise, and that can cause tissue damage, which triggers inflammation. Okay? This is one of the reasons why selenium can be so helpful to decrease antibodies in Hashimoto's. Selenium helps to quench the oxidative stress that's happening and allows the tissue a little more breathing room so it can start to heal. Okay? So iodine supplementation should be avoided in patients with Hashimoto's until their TPO antibodies are under control. There can be environmental triggers. A lot of environmental toxins have been, can cause tissue damage directly, and they've been implicated in causing the immune system to go out of whack. This is like another 2 hours plus presentation. We could spend a day talking about this, okay? Hopefully you are, even if you're not super well educated in the details, hopefully you're talking with patients about living clean, because that's a really important piece of this. And sometimes, you know, with my patients, I think the most important thing is getting away from plastic. So if someone has no awareness of this as a problem, you know, they're using crappy makeup and they're, you know, eating conventional foods and all this stuff is going on, the first thing I do is don't buy or store food in plastic. That alone is like a full-time job for someone who's not accustomed to it, right? Because they're like, oh my gosh, the salsa, I never really thought about it. There's plastic and glass, or what am I gonna do with my Ziploc bags? Like, there's so many more resources now. But that's really one of the first places that I start. We know that halogens like fluoride, bromide, chlorine, all can impact autoimmunity. BPA, phthalates, and parabens all can cause autoimmunity. Heavy metals, pesticides, really most toxins have been directly implicated with various autoimmunities. So you've really got to get them out. If you want more information on this, you can, I get no affiliation, but there was a great talk on this by Lynn Patrick. She's a naturopathic physician at a California conference that I sat in on April 2015, so you can probably find the recording of it if you want a more deep dive on this. It was excellent. I mentioned infections can be triggers. Several infectious agents have been studied as triggers, so you need to get these out. You might need to test patients if they're symptomatic for these and they've never been diagnosed or treated. A couple of key ones on here that I think we're seeing more and more: Lyme, you know, EBV, herpes viruses, H. pylori, candida. You know, these are things that we need to make sure we're screening for in patients when we're seeing autoimmunity or we're seeing unexplained infertility. Okay, intestinal permeability. So in order to address intestinal permeability, these are some of my favorite things to do. So glutamine, 5 to 10 grams per day. Glutamine, you can take it as a capsule, but it's kind of bulky. And as a powder, it has like a little bit of a bitterness, but it's not too bad. So usually I recommend it as a powder. It's easy to mix in. One of my very favorite kind of naturopathic things we learned about for gut health was to do a cold infusion overnight of marshmallow root. And you can use slippery elm as well if there's like other discomfort. What that is you basically put, you know, I keep it pretty easy for patients. I say buy a big mason jar, throw in a tablespoon of each of those herbs with cold water, leave it in the refrigerator overnight. If they use hot water, it basically becomes like goo. It's kind of gross. And then you strain out the herbs in the morning, you add the glutamine to that jug, and then drink it through the day. Okay? Easy way to get the glutamine, and those other herbs are super soothing to the digestive tract. They're very mucilaginous, so they help with that kind of protective mucus barrier. Zinc is really important for gut health, and my very favorite is a form called zinc carnosine. Is anyone using this in practice? Zinc carnosine, it's particularly good to use overnight. Give it before bed and it prevents any kind of nausea. But zinc carnosine is particularly great at healing the gut lining. 20 to 30 milligrams per day. This is a pretty safe dosing. You don't need to be worried about patients becoming depleted in copper when you're using 20 to 30 milligrams per day. Okay. Probiotics, of course, I missed NAC. So NAC and glutathione. NAC has quite a bit of data on it. You want to use about 1.8 grams per day. So most capsules are 600 milligrams, and you take 3 per day. It's a great sulfur-containing compound. It's also a great antioxidant directly, and it's a glutathione precursor. So it helps us move more glutathione, which is a fantastic antioxidant. There's not a single study that I've ever seen. If anyone has one, I will give you hugs and kisses if you share it with me. I've not seen a study on glutathione as a therapeutic to improve fertility, but I use it all the time. All the time. It's like one of the only things that I would say is not directly evidence-based. It's very much evidence-informed, not an evidence-based therapeutic in my dispensary, but it's there and almost every patient's on it, and I love it as a master antioxidant. Remember, antioxidants help to quench the ongoing oxidative stress that causes damage, right? And when you have a damaged gut wall, you have a lot more inflammation and a lot more damage. One of my very favorite images that still sticks with me, and I use this with patients a lot, to explain like the role that inflammation has in kind of perpetuating itself. Let's say you have a patient where you know that they had Lyme disease, and you know that that triggered this massive inflammation, and then now they're testing negative for Lyme, and they're like, bam, better, don't need to do anything else. But you are still seeing a lot of signs of inflammation in the body. One of the ways I describe it, which just visually sticks with me, so maybe it'll be helpful for you, is one of my teachers shared with me that imagine a football field covered in mouse traps. And then they're always like looking at me with their head sideways at this point, like, where is she going with this? Now imagine on each of those mouse traps is a ping pong ball, okay? And they're all just resting quietly on this football field. And then you stand in the stands and you take a ping pong ball and you give it a big throw onto the field, okay? That's your trigger. Okay, that ping pong ball is the toxin, it's the infection, it's whatever that inflammatory trigger is. You throw it into this quiet environment, and when it hits the ground, what happens? It sets off a mousetrap, and then you have 2 ping pong balls going. And then when they land, you have 4, 8, 16, and before you know it, you have this massive amount of bouncing ping pong balls everywhere. You basically have an inflammatory disaster, right? But what happens when you go back in there and you take that first ping pong ball out? You're done, right? Everything settles back down to normal? No, it basically makes no difference, right? It makes no difference whatsoever because you have chaos ensuing. And what happens is that trigger causes the release of cytokines and of prostaglandins and all these inflammatory chemicals, but those chemicals don't go away right away when the trigger is gone. And they talk to each other and they cause more inflammation too, and they call all their friends. There's a big inflammatory party going on, right? So you have to give it time and you have to take a strategy and approach to actually calm that inflammation even once the trigger is gone. Okay, a really important thing to remember. And the glutathione and the NAC are 2 of my favorites to help with managing the oxidative stress and help that come back down. Quercetin is another one of those in that category, a great antioxidant. It works in a little bit of a different way. Quercetin is what's called a mast cell stabilizer. So quercetin has a big impact on the histamine reaction that we see with like allergies, for example. So when you think about Benadryl, your classic antihistamine, kind of quieting down, quercetin has a very similar mechanism. It helps those histamine-containing cells called mast cells get more stable so that they're not as reactive. Okay, they're not as easily triggered. Probiotics, I'm jumping back up here, but probiotics are extremely important. Of course, we know more and more about gut microbiome and the role that microbiome has on inflammation and on disease prevalence, including autoimmunity. So making sure that patients are eating fermented foods and getting a good, diverse probiotic is very important. And then N-acetylglucosamine. This is another compound that can be very helpful with rebuilding the gut lining. Again, it's one that's very mucilaginous, so it really helps with soothing and repairing the gut wall. Now, typically with this, I'll also pair it with a dietary change because foods can be a massive trigger for inflammation in the gut, and that's very personalized, right? So I like to do food allergy testing on a patient and or an elimination diet, which is kind of the master way to test. In order to, what that involves, in case people aren't aware, is you remove most antigens, from the diet. So they're eating very, very clean, avoiding foods that are common allergens, which in my book are gluten, egg, and dairy most commonly, and then secondarily like sorn. I'm making up my own foods. There's probably something out there called sorn, which is like a combination of soy and corn. So to make sure they're not eating sorn. And other foods that can be common triggers for them. So you can find protocols for this online if you've not created your own, but you're basically having them eat for a period of time, removing those foods, and then they test them in one at a time to see if they have a reaction to the food. Okay. There's also various blood tests that can be done to look at food allergies, and every practitioner that runs them has a favorite, and it's really debatable around which one's the most accurate, and you end up using the one that you get the best results on, I think. For me, I always follow up any kind of blood test that I do with a customized or tailored elimination diet to make sure that came back accurate. Also, some people are using the specific carbohydrate diet or the GAPS diet, and also just make sure you're doing a lot of lacto-fermented foods. Okay.